I'm Dr. Rakesh Nair. I'm an exclusive knee replacement surgeon practicing at Zen Hospital in Chembur. I'm also attached to the Fortis group of hospitals at Vashi and Mahim and the Holy Family Hospital at Bandra. Today I am going to be talking on bilateral one-stage total knee replacement. To understand the basic term which I have used here, when I say bilateral one-stage, I say both knees in one sitting. They are done together once the patient is wheeled in. They are not done in a gap of a few days. That's what I mean by both knees in one sitting. In the surgery, all we remove is hardly 7 to 8 millimeters of bone from the thigh bone and around 7 to 8 millimeters from the shin bone, that is the lower part. And all we do is just change the cap. It's like changing the cap of a tooth. So your bone and your muscle is your own. We are not chopping off the whole knee and replacing it. So that's the reason why I'm using the terminology knee resurfacing. We are changing only the cap. Once the cap is changed, we are able to mobilize the patient the same evening if required. And with the advanced anesthesia techniques that we have, I'm able to make the patient walk the same evening. So there are some videos here also which would tell you the same, where the patient has been operated in the morning. By around 12 o'clock, once he or she is wheeled out of the operation theatre, in another 4 hours, by around 4 o'clock in the evening, the patient is walking with full weight on the leg without much pain because of the pain techniques we have in terms of the pain management. Now, why would I say that we should be doing both knees in one sitting? So, what are the advantages of doing both knees in one sitting? If you see the further videos also which I would show you, most of the patients who come to me have severe deformities. They have like severe bow legs, legs which are severely bent either towards the inside or towards the outside. So doing one knee and then doing the other knee is not going to help at all because the patient is not going to be able to walk. So when I do both knees in one sitting, it restricts the surgical procedure. So it is like saying I do everything under one anesthesia. The patient gets only one shot of medication. The medicines also which go into the body is once. You are wheeled into the operation theatre once. The most important part is that the patient can be mobilized very easily because immediately both the legs are straight and the patient can walk with full weight bearing on both the legs. So I can make the patient walk in the evening or the next day depending on how strong the bones and the muscles are. Another thing is it reduces the hospitalization also, plus the hospital costs also go down because we don't doubly use the medication, nor is the stay doubled. The stay is the same. It varies between 3 to 7 days depending on how strong the patient's knees are before surgery. So I would definitely advocate doing both knees in one sitting. What are the main advantages, or what would you say in terms of why wouldn't we do a knee after a week or 10 days? So there are even studies which say that it is not the number of joints or the number of knees you do in which causes the problem, or the commonest cause which is infection. The problem arises if you keep on wheeling the patient into the operation theatre. So if somebody says that we do a knee today and then we do a knee after 4 days, 5 days, the chances of infection will increase because the patient is being wheeled into the operation theatre on 2 separate occasions. So it is not that I have done both the knees in one sitting, which is a better option because the chances of infection are less than doing one knee now and then doing the other knee after around 4 to 5 days, where the patient gets the same medicines again repeated, plus he is brought into the operation theatre again and his stay also increases in the hospital. I would be showing you some videos where how the patient is walking before surgery. If you see, most of these patients, the legs are severely deformed. So all of them I have been able to do a one-staged bilateral knee resurfacing where I have done both the knees in one sitting. You see them how they are walking before surgery, you will see them how their legs look after surgery. And if you compare the function, they are really able to walk very comfortably. My patients even sit cross-legged after surgery, but that is not, I'll show you one of these videos which is showing the patient sitting cross-legged after surgery, but that is not something which we promote. It is just to show that they get very good function and they would definitely be able to sit cross-legged, but that is not something we tell the patient to do because it compromises on the life of the knee. So there are a lot of records and results which say that whether we do a bilateral one-stage knee replacement or whether we do a one-stage knee replacement, the complications in terms of infection, embolism is always similar. In fact, it is much more in a unilateral knee than in a bilateral knee. We use body exhaust space suits again during surgery. I will show you this video which is showing you the body exhaust space suits where we are working in a very sterile environment. We would not want to give any infection even from the OT personnel to the patient. So these are body exhaust space suits which prevent the impure air breath out of the operating team. It's not allowing it to go to the patient. In fact, it is sucked up by a rotating fan, which is there on top of the body exhaust space suit, and the whole impure air is taken out from the patient's atmosphere. Even our conventional methods of mixing cement has been changed, and we are using basically vacuum mixing for cement again, so that there is no impurities in the bowl which we are mixing the bone cement to fix the implants to the bone. We have all the options in terms of the knee replacement, where we have even computer assisted total knee replacement. We have unilateral knee replacement, where basically the unilateral knee replacement is used for younger patients who have deformities or pain only on the inside of the knee, where only a part of the knee has been damaged. The rest of the bone is all right. So that's where we use a unilateral knee replacement. The latest what we have is customized jigs in total knee replacement, where we get the MRI done of the affected knee. On the basis of the MRI, there are custom fit knee, the ceramic jigs are made, and on the basis of the ceramic jigs, the positioning of the implant can be as perfect as required. Obesity the patient always comes up to me saying, "Doc, I am little on the heavier side. I am so heavy. Is it a contraindication to my surgery?" So obesity as such is not a contraindication to surgery. Definitely the chances of wound healing are a problem, but instead of that week to 10 days, it would take another week to 10 days for healing. Otherwise, it is not a contraindication to surgery. Now, a very important question which comes from the patient is, "Doctor, how long will this knee last?" So I give a very simple answer to that, is that the more you take care of it, the longer it will last. So the longevity of the knee all depends on how strong your muscles are before surgery, how strong your bones are after surgery or before surgery, and depending on that, I normally get a bone density done for the patient, and we treat the patient on either a yearly injection for osteoporosis or daily injections which are meant to fill up the bone, and that decides on how well the implant is going to hold on and how long the life of the knee is going to last. For further information, you need to contact me through lybrate.com.